Good morning, ladies and gentlemen. It's my pleasure to participate in the Great Wall Congress of Cardiology and share with my colleagues in the Asian Heart Society my presentation about the role of multimodality imaging in CRT optimization. As you know, the cardiac output depends on three components: the preload, afterload, and cardiac output. Based on guidelines for heart failure patients with severe LV dysfunction and wide QRS, the CRT is effective in restoring mechanical efficiency through contractor resynchronization. However, the limitation exists. 30% of patients exhibit no improvement and might even worsen symptoms after device implantation. Nowadays, the multimodalities imaging play a key role to select the patient who might benefit from CRT. Based on echocardiography, we study the pattern of motion and deformation, and if the patient has other concomitant cardiac conditions such as mitral valve disease, and we study as well the intraventricular delay and atrial ventricular and LV-RV time interval. And by CMR and multi-slice CT, we can study the myocardial viability and the distribution of fibrosis beside to coronary venous anatomy and lead placement. Based on M-mode in short parasternal axis view, we can study the delay between the septum and posterior wall motion. If it is more than 130 milliseconds, it's consistent with significant dyssynchrony. And then we can measure the VTI of LV output in 5-chamber view, and this by pulse Doppler, it helps us to calculate the cardiac output. Based on tissue Doppler, we can study the difference in time between the septum and tube on posterior wall, and it's more than 50 milliseconds. It's consistent with significant dyssynchrony. And also, we measure the difference in time from the beginning of QRS to the S wave prime in the septal wall and as well in the lateral wall. But this method is subjective and it's not relevant to use in clinical routine practice. Right now, I would like to focus on strain, and many studies demonstrated that the radial strain might allow more precise site selection for LV pacing to enhance reverse remodeling and to improve electromechanical synchrony. And then we move to interventricular delay, and I give you this the methods to use it and calculate the difference in time from beginning of QRS to pulmonic flow in RV output and the time from beginning of QRS to aortic flow in LV. And it's demonstrating significant delay in LV ejection if it's more than 40 milliseconds. And then we look on the pattern of pulse Doppler on mitral flow and look on the E and E wave. We have three patterns. If the A wave is absent or truncated, or the pattern of merged E and A wave, so the RV optimization is indicated. And also optimization might be considered if stage 2 pseudonormal or stage 3 restrictive diastolic feeling pattern are present. Go back to strain. This study published in JACC many years ago and studied the strain staging of left bundle branch block induced left ventricular remodeling in patients with septal flush. It showed that the LV ejection fraction and the value of GLS correlate inversely with the stage of left bundle branch block left ventricular remodeling. But the LV in diastolic dimension and the extent of septal flush correlated very well with the stages of left bundle branch block based on strain curve. This example of patient with heart failure with low ejection fraction, EF 25%, and the value of GLS 5.9, and you see based on the strain curve how is the dyssynchrony between the segment of septum compared to the posterior and lateral wall segments. That make us to focus on the strain curve, and this paper review about CRT optimization published many years ago, and this example of a case from the center where I did my PhD. And this is example of the patient with heart failure symptoms with improvement in his symptoms, and the curve before the device and after 3 months implantation. We show this case showed that the synchrony between the septal and posterior wall with septum segments after the 3 months device implantation. This paper published soon, my colleagues in the University of KU Leuven in Belgium focus on strain-based staging as a unifying concept in cardiac resynchronization therapy. This study showed that the stages of left bundle branch block LV remodeling based on a strain curve showed more correlation with late gadolinium enhancement studied by CMR, and also the change in LV ejection fraction and in systolic volume showed improvement after CRT device implantation in the stage 4 compared to other stages. Not only the ejection fraction and in systolic volume, but also the survival was better in group 4 compared to other groups and control. In this slide, I would like to show you the value of myocardial work in CRT therapy. This is a novel index that we measured by echocardiography, and we include the pressure overload, and we combine it with strain analysis to have the pressure strain loop, and we calculated the myocardial work index from these methods. This example from my center in OLV Aalst in Belgium, and we measure the myocardial work in the patient with CRT at baseline and after 12 months. And as you see here, the CRT increases the global myocardial work, and this inhomogeneity, this appeared between the septal segment and the other segments of the heart. This example of the patient with left bundle branch block and the MWH with septal flush, and also the patient has intraventricular mechanical delay measured 110 milliseconds, and the pulse Doppler mitral inflow revealed the fusion of E and A wave, and the termination of the A wave occurs after QRS onset. And then the myocardial work measured in this patient at baseline and after 1 week and after 4 months. And as you see here, the bull's eyes showed more synchronized between the segments of the heart compared to the pulse eyes color mapping in before the CRT device implantation. Not only for left bundle branch block, also we can use echocardiography to select the patient with non-left bundle branch block who might benefit from CRT. Based on visual assessment of LV dyssynchrony, the apical rocking and septal flush is a good sign and easy, useful and easy methods to use it. And also the strain curve, it helps us to calculate the systolic stretch index. It's a promising index, but it's relatively complicated and needs more study to compare it. And also this example of the patient with heart failure and severe mitral regurgitation, and this patient after 6 months and CRT device implantation and optimal medical therapy, the mitral regurgitation showed improvement. So it's very important to wait 6 months after CRT implantation to evaluate the valve. This is another example of the patient with severe mitral regurgitation, and the CMR showed high enhancement gadolinium in the septum and the posterior lateral wall, and the strain as well showed dyssynchrony between the anterior septum and the posterior lateral wall. And after CRT implantation, this patient still has significant mitral regurgitation, and it was candidate for MitraClip therapy to improve his symptoms. In this table, I would like to summarize the useful marker and parameters based on echocardiography. Based on guidelines, tell the criteria to select a patient who have benefit from CRT based on MWOD, and if the patient showed EF improvement and more than 15% in systolic volume reduction relative to the baseline. And also speckle tracking derived strain help us to determine the LV reverse remodeling. And also the promising novel index, the assessment of wasted myocardial work based on a pressure strain loop, describes strain dispersion due to load changes, but further investigation required in this field. This another table showing the advantages and limitation of multimodalities imaging in this kind of group of patients. Still, echocardiography is the cornerstone and widely used, and it's safe after CRT implantation, but the limitation is still subjective. And CMR right now is very useful to detect the focal and diffuse myocardial fibrosis, but it's high cost and limited availability. Multi-slice CT also it helps us to visualize of cardiac veins and evaluation of structural remodeling in patients with inadequate echocardiography images and CMR contraindication, but the limitation is the high radiation dose. In this slide, I just to focus on the novel treatment right now for dyssynchrony, and based on implantation in one lead in the septum in the area of left bundle branch area pacing. This is a systemic review of 5 published study and measure the global work index in a group of patients with left bundle branch area pacing, compare it to other pacing techniques such as his bundle and CRT traditional way. And this systemic review demonstrated that the global work index showed improvement in a group with left bundle branch area pacing compared to the baseline and compared to other group, but the p-value is not significant, and I think a multi-center study needed to confirm that. The key messages of this presentation, I would like to summarize. The left bundle branch area pacing is visible and safe and provide an alternative option for CRT and associated with improved clinical and echocardiography outcome. Secondly, the multimodality images have a vital role to identify CRT responsiveness, and echocardiography is the best modality to guide CRT optimization. Finally, speckle tracking based strain imaging provides a more detailed assessment of myocardial mechanics, earlier diagnosis, better risk stratification, and more personalized management strategies. And thank you for your listening.